Of course.
Well, well, thank you very much for joining us. All right, so it's my pleasure to introduce to everybody Gustavo Gomez. So, many of you are probably very familiar with much of the work. Those who aren't, Gustavo is somebody who is a pioneer in a lot of things, but especially with regards to the wrist and especially close to my heart with regards to arthroscopy and doing some really awesome stuff, pushing the field forward and sort of teaching us a lot of the cool things that we can do with the scope with regards to treating some of these really complex pathologies and with regards to thinking about things sort of a different way than we were traditionally thought. So he's somebody who has inspired me and can't wait to sort of see what he does in the future. But we are lucky to sort of be able to engage him today. So Gustavo, the floor is yours. Thank you very much for joining us.
Okay, thank you very much, Eric, for your generous invitation and your generous introduction. So I'm going to share my screen. Wait. Okay, here. So you can see my screen? Yeah.
Yeah, looks perfect.
Okay, great. So, thank you very much. I'm very happy to be here with all of you. So, I'm going to talk about arthroscopic management of intra-articular distal radius fracture, but I want to show you a step-by-step approach depending on the type of distal radius fracture that we can treat. So, of course, for this, it's very important if we can see this step-by-step approach using the AO classification because it allows us to organize better the things. So to put the things in order. So this lecture is based in this paper that we have published it together with Sanj, Kakar, Francisco Meliboski, and C. So the most important thing when we are treating a distal radius fracture is to restore the volar tilt, the ulnar variance, and the radial inclination. And this is what I call the macro reduction. And for sure, this is the most important thing. So this is the first thing that we have to do when we are treating a distal radius fracture. Then arthroscopy is a very useful tool to reduce articular step-off, gaps, and to identify and treat associated injuries. And this is what I call a micro reduction. So when we talk about B2 fractures, it's important to see if the dorsal fragment is more or less than the third part of the articular surface. When it's bigger, we can use a standard plate. We introduce the scope through the 6R portal and using Kapanji technique, for example, we reduce the fragment and then we direct the screw to the dorsal ulnar corner. Here we have a case, we can close the fracture with 2 or 3 key wires. As you can see here, pushing the key wires, we can push the dorsal fragment from dorsal, closing the gap as you can see here. Sometimes it's very difficult to really close the gap because we have a hematoma interposed. So we have to scratch between the fragments in order to remove the hematoma. And after that, we can reduce the step off. You can see that the blood is coming out from the fracture line because we are really closing the gap. Okay, you can see this anatomical reduction. These oblique views helps us to understand better the fragment and the direction of the screw. With this nice result in sagittal view at the scaphoid fossa, the lunate fossa, and in axial view we can see how we fix the dorsal ulnar fragment. If the fragment is smaller or there is some convolution, we should use any material that will give support from dorsal. Because if we want to treat this fracture with a volar locking plate, it's very difficult to fix this fragment because the screw, instead of catching or fixing the fragment, they push the fragment. So it's very difficult to treat this and we need any dorsal support. When we talk about B3 fractures, we have to see if the fracture line is proximal to the watershed line or distal to the watershed line. Proximal fractures can be treated using a volar standard plate. These kind of fractures are produced by a shearing mechanism, and volar subluxation of the carpus is very common. If the fracture involves the volar ulnar corner, I strongly recommend an ulnar approach, going ulnarly to the palmaris longus, so we can have a better access to reduce a fracture. And to fix the plate, we place the scope at the 6R portal, and we use the plate to reduce the fracture with the proximal compressive dynamic screw. We can control the reduction under arthroscopy. We check the stability of the fragment, and then we fix distal screw, as you can see here. With these nice results in sagittal view, coronal view, you can see how we can restore the shape of the articular joint, of the articular surface. When the fracture line is distal to the watershed line, we can use a volar rim plate, as you can see here, or a hook plate to have better fixation of this little fragment. This little fragment is usually a consequence of an evolution of the volar distal aspect of the radius. And if we want to treat this with a standard plate, we are going to fail because this plate cannot contain the fragment, and we are going to have volar subluxation few days after the surgery. So we have to contain the fragment. Sometimes the hematoma, as you can see here, is interposed and doesn't allow us to reduce the fracture. So we have to remove it with the shavers you can see here, and then we can achieve this nice reduction. For C1 and C2 fractures, we have to combine the same principles for B2 and B3, but joining together. So we can have this combination of these patterns, being the most complicated to treat, the one that have one small volar and one small dorsal fragment. And this is, for example, the case of a fracture dislocation, as you can see here. After a close reduction of the joint, it seems to be no problem. But in the CT scan, we can see this step off with this dorso-ulnar fragment, as you can see here. You can see in sagittal view that there is a step off of about 4 millimeters and a complete displacement of the palmar fragment. We can see in these cases a very important instability because these fragments usually keep the relation with the ligament. So you can see that the palmar fragment follows the carpus, as you can see there. So this happens because the lunate impacts the central area of the lunate fossa and passes through the dorsal rim, pulling the palmar fragment backward due to its avulsion. And this generates the comminution of the dorsal rim with many little fragments. So to treat this, we have to reduce the volar rim, and then we fix it with a palmar hook plate. We then place a dorsal plate. We fix just the proximal screw, and then we go to arthroscopy. So we place the volar hook plate and the dorsal specific plate. We fix just the proximal screw, and we go again, I repeat, we go to arthroscopy, introducing the scope through, placing the scope through the 6R portal. So then we reduce the central depressive fragment with the probe, for example, to elevate this fragment, and then we place distal screw in order to hold these articular fragments. If everything is okay under arthroscopy, we can do the rest of the fixation. We can go with the rest of the distal screws. This is the volar approach with the hook plate. You can see at the right of the screen, and the dorsal approach is just 3 centimeters and a half. And you can see that we just fix proximal screw, as I said before. we reduce the articular fragments at the articular surface. You can see this central depressive fragment. So we introduce a probe in the fracture line and we try to rotate this fragment in order to elevate this fragment and put this fragment in the same level of the rest of the articular surface. And after that, we fix distal screws with this intraoperative result. And here we can see that the ulnar fragment is well reduced at the right of the screen, as well as the central depressive fragment. Same in sagittal view, you can see the central and palmar fragments. You can see at the right of the screen the reduction, and the same at the level of the scaphoid facet. And in this axial view, we can see the reduction and fixation of the dorso-ulnar fragment. We can use some tricks like rotate fragment with the probe, pulling the fragments with the probe, or push the fragments from below through a window on the volar cortex to restore the articular surface of the radius, as you can see here. For C3 fractures, I think that the most important thing is to check if we don't have or if we have a central depressive fragment. This is a case in which we have some convolution, but there is no central depressive fragment, as you can see in this coronal view. In this axial view, you can see the convolution of the dorsal aspect of the radius. And here you have sagittal view, you have at the level of the scaphoid fossa and the lunate fossa. We use a key wire to restore the ulnar variance and the palmar tilt and the volar tilt and the radial inclination. But if you can see at the right of the screen, you can see that we haven't restored yet the volar tilt. So we use indirect reduction with a volar locking plate, a volar standard locking plate, fixing the distal screw, and after that we fix the proximal dynamic compressive screw in order to restore the volar tilt. So after that, to hold the convolution, the dorsal convolution, we have to use a dorsal specific plate to replace, to take out the key wire. So if you can see here, you can see a very nice reduction under fluoroscopy. So we go to this minimal invasive dorsal approach in order to place just this dorsal specific plate. And you can see here the very nice reduction under fluoroscopy. So I want to ask you, and be honest, how many of you end the surgery and go home? Okay, I have done this many times, and after I start to do arthroscopy, I want to see and to check these kind of fractures. So, well, after I went to arthroscopy and I found a step off of about 3 millimeters between the radial styloid and the dorsal aspect of the scaphoid facet. So we remove the screw that was fixing this fragment. We remove the screw that was fixing this fragment, we reduce it, and we lock this screw again. We can use dorsal support with the finger or with any other tool, and then we can lock this screw again, and you can see at the right of the screen the nice reduction that we can achieve after this maneuver. So now we have the X-ray, but I always like to see the CT scan after the surgery. So you can see this coronal view with this nice reduction. This axial view, you can see that we have contained this dorsal convolution with the dorsal specific plate. And in this sagittal view, look at the left. This is the fragment that we had to reduce it. When we have a central depressive fragment, things change because we cannot use ligamentotaxis to reduce the fragment, because this central depressive fragment has no connection with the peripheral fragments. Sometimes it's difficult to identify them on X-rays, as you can see here. So we have always to order a CT scan in order to see and to identify these fragments before the surgery, to plan the step by step and identify this fragment in all the sagittal and coronal view. So we can see under image intensifier, we have this dorsal fragment, we have the central depressive fragment and the volar fragment, and the carpus is impacted on the fracture. So to reduce it, we usually think that compressing the plate will help, but this is wrong because it becomes very difficult to disimpact this fragment once it is stuck among the other fragments, and this is a big headache for the surgeon. So it's better to place the plate and just put a key wire without compressing the plate, so we reduce the fragment by arthroscopy while we compress the plate. We can place the screw, but don't compress it yet. As you can see here, the plate is not compressed. Then we release the fragment, pushing them from the fracture line. We remove the hematoma scratching between the fragments. We pull the fragment with the probe while we are compressing the plate, placing the proximal dynamic compressive screw. And here is the result under image intensifier, but of course we have to check again with arthroscopy. Here we can see that we place the distal fixation, and here is with arthroscopy, touching each fragment to check the stability, because it's very important to put a screw below the fragment to avoid the collapse of the fragment after the fixation. You can see here the fracture line. We have a very nice and anatomical reduction. And these are the final image control. Sagittal view in the CT scan and coronal views, you can see the fragment that is well reduced, and we have placed some screw underneath this fragment to avoid the collapse of the fragment. This kind of fractures with central depressive fragment can involve the scaphoid facet, like this case, and we always have to reduce the fragment before compressing the plate. You can see how it's very easy under arthroscopy to manipulate this fragment with the probe. This fragment was completely in a vertical position, completely rotated. So we then rotate the fragment, and after that, we can compress and close the fracture line by compressing the plate. So then we compress we can do a temporary fixation and compress the plate, and then we go to definitive distal fixation. And you can see here the CT scan in sagittal view. I always like to check the position of the fragment, and the screw with this CT scan always has to be screwed below the fragment to avoid the collapse of the fragment after the surgery. I want to repeat this again because for me it's very important. As you can see here at the right of the screen, we can see the same in coronal view. This is another case involving the lunate facet. You can see the central depressive fragment in the lunate facet. We place the plate without compressing, just with key wires. In arthroscopy, we can see that the fragment was completely rotated. So we took the fragment with the grasper and with the basket, and we rotate the fragment to put the cartilage looking to the joint again. It's impossible to do this and to treat this, to identify and treat this kind of rotation of the fragment just under image intensifier, because you cannot see where the cartilage is looking to, because the image intensifier don't shows us this kind of information. So in these cases, for me, it's very important to do arthroscopy. And then we can check the stability of the rest of the articular surface. It's impossible not only to see, but also to solve these kind of problems without arthroscopy. And this is the result on arthroscopy. The fragments are in a very good position. And this is the result in the CT scan. You can see the coronal view. You can see three screws underneath these little fragments. So sometimes it's almost impossible to fix this fragment, because if you want to pass the drill and the screw through this little fragment, you can destroy this fragment. So it's very important to fix some screws underneath these fragments just to avoid the collapse of the fragments. And you can see the control in sagittal view too. So in conclusions, and I don't want to do it more long. So in conclusion, remember always that the most important is to restore the normal angles of the wrist. Plan the surgery depending on the fracture pattern, and go step by step depending on the type of fracture that we are treating. So why do we perform arthroscopy? To see, to reduce, and to check, so we can understand, we can act, and we can be sure that we are doing the best for our patients. Thank you very much.
Thank you very much, man. That's awesome. Um, as usual, incredible talk, and love your animations. Those are just phenomenal. Um, why don't we open this up to the floor then, and we can sort of engage a bit.
Gustavo, I apologize. Oh, sorry, I'm frozen. I was going to say, I apologize. I joined a bit later. I was having to deal with some other emergent issues. But when you do arthroscopy fairly routinely on most of these distal raised fractures, are you looking and addressing other pathology at the same time, such as SL issues, TFCC issues, or are you more focused and say, look, let me get our articular reduction perfect and worry about some of these other things that may or may not have been there before or after their injury and see how they do first? Or what is your thought process?
Well, yes, I think it's very important to check and to see the preoperative studies, of course. But most of the time, I just go to surgery with the X-ray and the CT scan. I never order an MRI to see the associated injuries. I don't think it's necessary. And of course, you have a big hematoma inside the wrist, so it's very difficult to identify the associated injuries. But in the CT scan, for me, it's very important to see the alignment of the carpus, the alignment of the distal radioulnar joint. So for me, this is the most important thing. If I have a big DC deformity, an important scapholunate instability with an static instability. So in these cases, I do a pinning of the scapholunate joint, okay? And you can add a dorsal wide capsulodesis to reinforce these kinds of injuries and the tissue. But if I have a well-aligned corpus and I found a scapholunate injury, but I don't have any instability in the CT scan, so I don't do nothing. You know why? Because this is very different. You have to think in this pathology in a very different way from the patient that comes to your office with a chronic scapholunate instability. This kind of scapholunate instability has a very important potential to heal. Okay, so I think that you just need to put things in order. Okay, so in the same way that if you have a fracture of the distal radius with a non-displaced fracture, so you don't do nothing, you just leave it there because the biology is going to do the rest. Okay, so the same is here. If the carpus is well aligned, I don't do nothing. Okay, but if I have a static instability or a DC deformity, okay, I do a reduction and I do a pinning. okay? And you don't need to wait for 4 weeks or for 6 weeks, because most of the cases, as you are treating an acute trauma and an acute injury, most of the cases you're going to have a good heal at 2 or 3 weeks after the trauma, not the surgery, after the trauma. So this is very important for me. So I don't delay the physiotherapy or the rehab in these cases. And the same with the TFCC. You know, the 70% of the distal radius, of the intra-articular distal radius fractures, has an injury on the TFCC. So how many of you that don't do, or for example, when you don't do arthroscopy, how many of you don't treat the TFCC many times, and you have no problems because you have an acute injury? Okay, so the biology is going to heal this. The problem is if you have a subluxation of the distal radial ulnar joint, or if you, after you do an anatomical and a nice reduction, you have still a distal radial ulnar joint instability. So in these cases, I do just a foveal reattachment of the TFCC.
Do you always go mid-carpal and look at the SL and LT, or are you only doing that if you see gapping or DC or something like that?
No, just if I see a gap or a DC. If I don't do it, I don't see or check the SL in every single fracture. No, just if I see something wrong in the CT scan.
Yeah. Nice.
Dr. Gomez, thanks so much for sharing. Really great talk. I'm Anthony. I'm one of the hand fellows here.
Thank you.
Mentioned getting postoperative CT scans. I was wondering if you do that pretty much in every case, and if there's anything that you might see postoperatively that would make you want to take somebody back for whatever reason. Do you have a threshold for that?
Yes, you know, for me, it's very important to think about this. It's very important that sometimes when we have an intra-articular fracture with for example, a little central depressive fragment, we can just identify this fragment with a CT scan. I think that all of you, and including me, order a CT scan in any intra-articular fracture, because sometimes we can have a surprise, okay? So for me, it's not correct, just for me, this is my humble opinion. For me, it's not correct if you do an X-ray for a patient and you see just a simple intra-articular fracture line, and you say and you tell to the patient, okay, we need to do a CT scan to check exactly what is happening inside the wrist. And after that, when you do the CT scan, you see, for example, a central depressive fragment that is completely rotated with a step off. So you sometimes tell to the patient, oh, this is an indication for surgery. I need to do the surgery, so I need to reduce this to restore the anatomy of the wrist, okay? And after that, you go to surgery, to the operating room, and you treat this patient just under image intensifier. So we don't see the fracture, exactly the pattern of the fracture under X-ray, but then in the operating room, sometimes we just use the fluoroscopy or the image intensifier. So, and after that, you control the patient in the postoperative just with X-ray. So it's very difficult for me to think that this is correct, because you do the indication of the surgery with the preoperative CT scan. Then you use image intensifier in the operating room, and then you use X-ray in the postoperative follow-up. So for me, it's important to do the CT scan before the surgery, to do the CT scan after the surgery, to see if I do it right when I do the surgery, and to use arthroscopy in the operating room, because arthroscopy is like having a CT scan inside the surgery. So you can evaluate the step off, exactly the reduction of the step off or any gap. So in the follow-up, sometimes in the CT scan, we have big surprises. So I have to be honest with you, after I see the CT scan, in just a few cases, I decided to go again inside the operating room to restore the articular surface again, because I saw that I did it wrong. And sometimes it's a young patient, so I don't want to leave a step off in the middle of the joint. So the CT scan can give you some information to do some things again, to repeat the surgery again, for sure. And lucky for me, it's just a few cases in many cases with intra-articular fractures with arthroscopic assistance. And if I see that in the CT scan that I have a nice reduction, but the fragment has no screw exactly underneath, so I can delay in these cases because I have a lack of stability. In these cases, I can delay the rehab to 3 or 4 weeks in order to have some casus to avoid the collapse of the fragment. I'm sorry about my English. I'm trying to explain it in the best way.
Gustavo, you're doing great.
I hope you on. Oh, thank you.
You're doing absolutely fantastic. The talk.
I hope you
every time I've
understand.
heard you speak, it's always been fantastic. You're doing great.
Thank you.
No,
I
thank
have
you.
another question for you. I'm gonna supersede my fellow. What Wax reviewed.
Gotcha. You're supposed to let the fellows ask them questions.
I know, but hold on. I have my own stuff. Is there a time point of which you say the fragments are not going to be as mobile as you want when you're in there arthroscopically, that you like, hey, I have to now do like osteotomies to try and get the pieces up? I mean, obviously you may tell, but if let's say someone shows up to you with a significant intra-articular distal radius at 4 weeks, does that change what you do, the order of what you do, as opposed to getting to them at 1 week where things are fresh and easy?
Yes, I think, in my head, I cannot tell you that I have evidence about this. It's just my experience. In my experience, inside my head, if I do the surgery at 1 week or 2 weeks after the fracture, I think I will have no problem to reduce the fragment just with the probe, or just in a very easy way. The problem is after 3 weeks. After 3 weeks, we start to have some casus, fibrosis that doesn't allows us to reduce it easily with the probe. So sometimes we have to push the fragment, we have to scratch between the fragments in order to reduce and move the fragments in the direction that you want to move it. So sometimes the first thing that I do is just touch the fragment and try to move it, pulling from the fragments with the probe. If I see that it's very easy, I go with the rest of the surgery. But if I see that I have a problem and the fragment is not moving just with the probe, I try to not to pull and do more strength, because you're going to fracture this fragment. So you're not going to have one fragment, you're going to have 2 or 3 fragments. And this is a big headache. So in these cases, I go again to the fracture line, I try to push the fragments from below, I scratch, I move. And in my experience, after 6 or 8 weeks is when you have to do an osteotomy. So we have published our technique of intra-articular osteotomy under with arthroscopic assistance. I think that Eric invited me last year or 2024 to talk about this, or in Washington. In Washington was last year in Washington, and we talk about this intra-articular osteotomy under arthroscopic assistance. I have to do it years after the fracture.
Yeah, it's very nice. They have a very impressive series of music. Um, that's awesome. Tim or Kim, do y'all have any questions?
Yeah, that was a fantastic talk. Thank you so much. Tim Westbrook's one of the other hand fellows. Um, I have two questions. Could you kind of go through your workflow, how you actually do this intraoperatively? What are you doing before you put them up in traction? And then how much are you going back and forth out of the traction tower? And then my second question is, have you noticed a decrease in the need for dorsal spanning bridge plates with arthroscopy?
Sorry, can you repeat me the last question?
Second, so we in at least in the US, I feel like there's
Yes.
kind of a rise in using dorsal spanning bridge plates for especially for type C AO distal radius fractures. And I noticed in your talk you didn't mention that, and so I was curious if you've noticed a decrease in the need for dorsal spanning bridge plates.
Well, I'm going to start with the second question. I think I really decreased to use this kind of spanning plate, but it's just an opinion. It's just my experience because after I start to do arthroscopy, one of the best things while you are doing arthroscopy is that you are doing arthroscopy under traction. So it's a very similar effect that gives you the spanning plate. So in this kind of injuries, when you have a traction, when you place the wrist in the traction tower, you can see that many fragments goes to its place just by their own, just because of the traction. So for me, when I start to do arthroscopy, very for many, not for many, but for some years, I have many cases of intra-articular fractures. So in my learning curve, I decrease the use of spanning plate because I start to see very good and nice results just with arthroscopy using the traction tower. And now going back to your first question, this is well described in the paper that I share you, but I think it's not available yet. It's going to be available in 1 or 2 months. But the thing is that what you asked is very important because it's one of the most important things that people wonder to themselves while you are doing your first, your second, your first cases. Because when I do the approach, when I place the wrist in the traction tower, I go forward, then I go backward, so it's very difficult to manage this. And everybody hates you in the operating room, the nurse, the other surgeons, because it takes a lot of time. So it's very important to do it always in a very practical way. So what I usually, not always, because it depends on the case, what I usually do is to do the conventional open Henry approach. Okay, I do exactly as everyone do the distal radius fracture. Okay, and I do the approach. I go to the radius. I remove the extra-articular hematoma. For example, I do the reduction of the volar cortex, for example. And after that, what I usually do is to see under fluoroscopy and to do my best to do the best anatomical reduction I can do under image intensifier. I don't think about arthroscopy. I just think I want to do my best under image intensifier. Okay. And then I usually place 1 or 2 key wires. First of all, I place 1 key wire at the floor of the second compartment. And I usually restore the wound variance, the radial inclination, and the volar tilt just with 1 key wires of about 1.5 millimeters at the floor of the second compartment. Okay. If I see that I have a very good reduction and I don't see anything wrong at the image intensifier, so I place the plate, the volar standard plate, but I place just the volar compressive screw, okay, the volar dynamic compressive screw, non-locking screw at the oval hole. So I place this screw in order to compress the plate against to squeeze the plate against the volar cortex, and after that I place sometimes 1 or 2 or 3 temporary key wires through the plate, trying to go through the distal fragments. And after that, I go to arthroscopy. And in arthroscopy, you can have, in my experience, 3 situations. One situation is that you enter and you say, oh, it's fantastic. It's fantastic. I have a very good anatomical reduction. So what do I have to do? Nothing else than placing just the distal screw. So I just place the distal screw. So I take out 1 key wire, I pass the drill, and then I place 1 screw. And the same with the rest of the distal holes, okay? So there you finish the surgery, okay? The second situation is that you see a little bit of step off. So you see, oh, I have a little bit of step off, 1 or 1.5 millimeters of a step off. So I take out the key wire that is fixing this fragment in order, so I take out the key wire in order to restore to reduce this step off. And after that, I go forward again with this key wire. And after that, I try to check so you can do little things, little maneuvers to do little things because you have a little bit of step off or a little bit of gap that you haven't seen in the image intensifier. And the third situation that, lucky for us is the less frequent. The third situation is that you enter and you see a complete disaster. And sometimes you see a complete disaster under arthroscopy, but you haven't seen before under image intensifier. You thought that everything was right. So sometimes you have a complete disaster. A fragment is completely rotated with the cartilage looking inside the bone. You have a big step off, a central depressive fragment that is completely depressed because the image intensifier can lies because it shows you just the peripheral cortex, so can give you a false image of the articular surface. So sometimes I have to remove all the key wires and start again under arthroscopy. So I start again with 1 fragment, 2 fragments, the third fragment. So while I'm reducing 1 fragment, I place the key wire, a new key wire. Then I reduce the second fragment, so I place a new key wire, okay? And after I place everything, after that I go to distal fixation. So it's open approach, then the traction tower, I do arthroscopy, I check, I do whatever I have to do, I place distal screw, and after that I go again to the image intensifier, because one of the things under arthroscopy, which is very difficult to see, is exactly the direction of 1 or 2 or 3 screw. It's very difficult. You can see that you are fixing the fragment because you see that the fragment is not moving. So you say, oh, I'm good. I'm fixing the fragment. But sometimes you can, and you know that you are not intra-articular with the screw because you saw it under arthroscopy, but sometimes you have a bad direction of the screw. So I go again to fluoroscopy to check if everything is okay. And if I don't like the position of any screw, I just change this screw.
That's perfect. Thank you.
That's awesome.
Thank you, Tim.
Gustavo, can I push you a little bit on this? So you just mentioned that, okay, as a disclosure, I do like the dorsal fan plate. And so I want to push you a little bit on the dorsal fan plate comment, because you said that when you put it in traction, it reduces via some of the external ligaments, it reduces a lot of the fragments. Not all of them, obviously, especially central portions, but reduces a lot of them. And so based on that logic, it would make sense to me then, depending on, so my, as a background, like I like to do dorsal plate, but then I augment it with some sort of fragment specific plate, kind of like you showed volarly or dorsally or whatever you need to do. I guess my logic is if you reduce it with traction, and so you get the slash reduction, then you go fix it however you want to fix it. Why not keep that same augmentation, that same traction for 8 weeks, and then let everything heal, and then take it off, and then let them get moving. But at least you sort of maintain that same traction that you had, that same reduction that you had, while also supplementing it with some sort of rubber plate. As a background, we do a lot of this where we do a dorsal plate for about 8 weeks. We take it off after 8 weeks, 6 to 8 weeks, but have some, we call it hybrid approach, where we have some sort of other supplemental fixation in addition to the actual bridge plate. The idea is that, you're right. When you get traction, you get this reduction, you put it on. So in my mind, like, why not then after you're done, put it back in traction, at least for a little while?
You are totally right. I totally agree with you. So it's just different way to treat the same problem, but I think both ways are correct. I think it's just different ways to treat the same, but
Sure.
it's very logical what you said. It's very intelligent because why don't to keep this traction that allows you to reduce the fracture? So
Yeah.
I think this is a very nice way. I have treated many patients with the spanning plate. I'm just not using them in the moment, but I
Sure.
think it's a very nice tool. I don't think it's a crazy way to treat a patient. No, 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 no. I think it's a very nice tool. Sometimes in a few cases, I use the spanning plate in some cases that I see that is completely destroyed the articular surface, because sometimes the comminution is so big that you enter with the arthroscopy and you don't see any cartilage. You just see bone, 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 fragment, fragment, fragment. So what can you do by arthroscopy? Nothing. You have it's like a bag of fragments. So in these cases, I think the spanning plate is very useful. And in the other cases, that I see that I can solve the problem without the spanning plate, well, I try to do it because it's just the difference between keep the immobilization or to delay the rehab between 10 days against 6 or 8 weeks. It's just that. Sometimes I do surgery in professional sport players, and they give a lot of pressure to you to go back to their sports as soon as possible. So sometimes if you tell to these kind of patients you're going to wait 6 or 8 weeks to start, you have to do a new surgery, and after that you're going to start the rehab. So sometimes you lose these patients, and so they go to the surgeon who is doing the consultation just next to you. So sometimes, yes, exactly. So sometimes I think it's just a tool, but I don't think we have to get married with any method. All the C3 fractures must be treated with the spanning plate, or all the C3 fractures must be treated with a volar or dorsal locking plate without the spanning plate. I don't think any treatment is better or superior than the other one.
Gustavo, to that extent, I was actually going to ask you on something in similar line. Do you have an
Yes.
age cutoff where you say, look, I'm not going to scope these dusted intra-articular patients that are 70 years old? Because those are the ones where obviously Eric and I get concerned that their osteoporosis or their bone quality is so low that a lot of the fragments settle, to your point, around the plate or around the screws, which is where we're often doing these hybrid fixations. I mean, those are the patients where I say, look, I don't know that it matters. They're 75 or 80. I just got to get their alignment somewhere close because they're not they're not going to do stuff. So why go try and do a heroic, surgery versus just span them out for a period of time?
Okay, just as a caveat to that, I still scope those, Gustavo. Don't listen to Gotchuk. He's making up he's imposing his beliefs onto me. So I do agree that back in with the bridge plate. I still scope those. So Gotchuk, stop imposing your beliefs onto me.
Well, I started to do arthroscopy 17 years ago, and when I start to do this, in that moment, I didn't learn a lot of arthroscopy from nobody at the beginning because there were no too big experience about this kind of things. So what I did at the first time, I think for the first 3 or 5 years, was to scope every single fracture, including the extra-articular fractures, because I want to know if I can do something else, if this tool can give me something to offer to the patients. So one of the things that I found was that you don't have to do arthroscopy in extra-articular fractures. It's not necessary. You never do absolutely nothing. Just remove the intra-articular hematoma, but it doesn't give any advantages to the patient, so it's not important. And the other thing that I have learned about this was exactly what you said, that in some patients after 75 or 80 years old, sometimes the most important thing, as I said in my lecture, is to restore the volatile, the ulnar variance, and the radial inclination. And I just do arthroscopy in this kind of elderly patients if I see just that there is a huge step off or something that I'm not being able to reduce it with any extra-articular maneuver under image intensifier. But, or I do arthroscopy if, for example, I have a fellow that tell me, please do it, I want to see how you can reduce this. Okay, but I don't think you can give to a very big advantages to these patients. Yes, I think the same as you.
So then
Eric apparently doesn't. He's going to scope all 80-year-olds.
That's cool. Anybody that's intra-articular alignment, there's no disadvantage in at least knowing what you're dealing with. There's no disadvantage. It doesn't add that much time to the case. There's no disadvantage.
Yes, I know I think this is a very important point. It depends on the time that add to you.
We must work in different locations of the amount of time it takes to scope stuff.
Well,
Does not add that much
is
time.
this is very important because in my operating room, to do the arthroscopy, it takes to me just 5 or 10 minutes.
Agree.
No more than that. So if I can enter, see, check, or move something, I can do it in 10 minutes. The problem is when you have a complicated operating room with complicated people that don't want to do arthroscopy, so it's very complicated, everything. So sometimes it takes a lot of time, so you have to put in balance.
Totally agree. Totally agree.
Mm. But at the beginning, it's difficult for everybody. The only way
But
it takes just a few minutes is to do it, to do it, to do it, to do it. So everybody knows how to do it, how the step of the surgery is. So this is very important to go ahead with arthroscopy. I think you have to do.
Do you have
that's a
suggestions
point
for
I
a
want.
fellow?
Wait, gotcha. That's a point that I want to make to the fellows. Tim, Cam, Anthony. Like, did you hear what he said? The first 5 years, he scoped everything. My point is, like, if you're gonna only scope the really really hard ones, your whole system is gonna have a lot of challenge doing it. Your scrub techs aren't gonna be able to do it. It's gonna take forever to set up. The equipment's not gonna be right. It's gonna be a total cluster. If you really want to actually do this, you have to scope everything for your own learning curve and your center's learning curve. And then it becomes expedition. Then it doesn't add much time. So it's really something you have to kind of jump in with both feet or don't do, at least in my mind.
Exactly. This is very important to roll the learning curve. And for the first many years, I have been doing this just for free because the health insurance didn't allows me to do it, and I do it anyway for free, just for free, because I want to learn it. And I think this is very important. Sorry, Michael, you were talking.
No,
Sorry.
it's okay. I think the points are valid. I mean, we say this a lot for a lot of the other things too, that you have to do enough of it to actually get to your point. If you're only going to scope the difficult ones, or what Wag said, if you're only going to scope the difficult ones, it makes it much harder for the system to do. It also makes it harder for you. So that makes sense. My question for you is kind of what for the fellows. The anatomy is often distorted of the wrist, so it makes doing the scopes a little bit more difficult or challenging to get the scope in or figuring out how you do. Was there anything that when you were first starting that you cheated by either putting a K-wire in the joint or putting a needle in the joint and taking a fluoro that you said, hey, this is where I need to be. I'm not mid-carpal, I'm radiocarpal, or et cetera, or making sure you weren't going to damage tendons? Was there anything, or was it more of just like, look, I tried to do the best I can and this is where I went? Or what takeaways did you have?
The question that you have done is very important because the anatomical thing that you see to do the 3-4 portal is the Lister tubercle. Okay, and most of the cases, this is completely destroyed in any C3 distal radius fractures. So sometimes you don't have any anatomical repair to know where is the 3-4 portal. So sometimes you have to see other things. Anatomy is very important to see. If you cannot identify the Lister tubercle, you at least have to know where is the 3-4 portal in relation of the distal things, the scaphoid, the lunate, the scapholunate joint, the mid-carpal joint. So it's very important to see this. Sometimes, as you said, at the beginning, I used to place a needle under fluoroscopy before going to the traction tower to do arthroscopy. I think this is a very useful tip, as you said, Michael. And the other thing you can do is, in the same approach, you can go a little bit distally, okay? And you can place just a key wire through the distally to the volar rim, and you can place a needle or a thin key wire through between the radioscaphocapitate ligament and the long radiolunate ligament. There you have a little hole, so you can place the key wire and you can go through the wrist. And then you can see here in the skin the protrusion of this key wire. So you know that the joint is exactly there. So there you can do the 3-4 portal. Otherwise, sometimes there is no Lister tubercle, so sometimes you have to do these tips in order to orientate your mind and to see where is the portals. Because if you do the portals in the wrong position, as any arthroscopy in any part of the body is the same. If you do the portals in a wrong position, you're going to be very uncomfortable for the rest of the surgery.
Yeah, those are great tips. That's exactly what I was hoping you'd tell them.
Thank you.
That's fantastic. Anybody else have anything else to ask him, or? Perfect. Oh, Cam, go ahead.
Yeah, I was going to ask, this is in relation to your article. How often are you using like a volar portal to look for like dorsal specific fractures that may require like dorsal plating? Is that
okay? The volar portal is very, very, very rare. I'm sure about this. Most of the time, you can see the dorsal ulnar fragment just placing the scope at the 3-4 portal, and then if you turn the scope and you look in this direction, you can see if you look ulnary, okay, and you turn the scope, you can see, or you turn the 30 degrees of the scope, you can see exactly the dorsal aspect of the lunate fossa. So sometimes it's not necessary to do the volar portals. For me, it's not the most common thing. I don't recommend you to start with a volar portal. This is when you have uh, a big experience trip. But for me, most of the cases, and I don't want to say the 100% of the cases, but most of the cases for sure can be treated just with the 3/4 portal and the 6R portal. I'm sure about this.
Thank you.
Yeah, great. Awesome, Gustavo. Well, thank you very much. This was fantastic as usual. So much fun listening to talk. We look forward to. Are you going to be? Well, I assume we'll see you many times, but you're going to be in Boston this fall.
Yes.
Beautiful.
I'm going to be in Boston. Yes, for sure.
Beautiful. Beautiful. We'll look forward to that, and yeah, I appreciate everything that you're doing. I don't know if you heard, we are establishing the North American Wrist Association, North American Wrist Arthroscopic Association. So similar to what y'all already have. So the idea is, hopefully we can kind of store a copy of you guys and actually catch up with everything. So. But yeah, look forward to seeing a lot more of you. Actually, one quick question before I let you go. I've had a lot of texts from people on this thing complimenting your animations. Do you have an artist that does those? Are you doing those? Like, how are you doing those amazing animations?
No, I do it by my own.
You do?
Yes, I use, it's going to be funny for you, but I just use Keynote.
Wow.
I draw
Phenomenal.
I draw the bonds, and
Yeah.
then you can move the bonds in the Keynote with the magic movement. Okay,
Wow.
you
Yeah.
put one bone in one position in one slide, and then you can put the same bone in another position, and when you apply the magic movement between like a transition,
Yeah.
okay, movement, the Keynote just do it exactly the movement between this position and this position by its own. You don't have
Fantastic.
to do the animation. Like, yes. And I draw some years ago all the bones in a software which is called Blender. So, and I just have the bones, and I put the bones in the Keynote, but I don't use the Blender anymore. I have the bones in any position, so I just move the bones in the Keynote. It depends what I want to say.
That's awesome.
Eric,
Wow, very cool.
Michael, and Nina, thank you very much for your invitation. I'm very happy to be here with you. Thank you very much. It was really a pleasure for me to be with all of you, with all the fellows. Of course, everybody, the fellows, and you can text me whenever you want, by mail, by Instagram, by WhatsApp, wherever you want. We can share cases, we can share whatever you want. It was incredible to be here with you. So I can be in another journal club that you have a session, and in another session in the future.
We'd love to
Awesome.
have you, and we look forward to seeing you in Boston. Drinks are on us. We'll see you there.
Yes, absolutely. See you, Gustavo.
Thank you very much. Nice.
Nice to see you.
Thank you.